Welcome to Examination of the Chest, Part 2. We're starting off this session trying to build on the basic physical examination skills and go over some of the actual lung diseases and how they might present and how we might approach that through the examination. There'll be a little bit of overlap with what you may have already learned in pneumonia. That's a very common disease, so we'll cover that briefly, and you can refer back to your lecture on that. So several of the common chest diseases that you'll see, again, this is not a comprehensive list, but would include pneumonia, COPD, asthma, lung cancer, and what I mentioned, large or locally advanced, meaning on examination of the chest, you're not able to pick up or evaluate very tiny early lung cancers, but as cancer develops, progresses, or causes other problems within the chest, it will be evident on your physical exam. Congestive heart failure, I'll just cover that briefly. It will be covered under your other cardiac lectures. Pulmonary fibrosis, which I'm using as a very broad term. There are many different types of specific illnesses that cause fibrotic changes. So there's not really just one disease, pulmonary fibrosis. Pneumonia, again, part of this is review. The primary illness that we think of as the prototype for this problem is acute community-acquired pneumonia. You'll recall from your talk by Dr. Morales that we actually have different categories of pneumonia, including hospital-acquired or ventilator-associated, that primarily are issues because of different organisms, different causative organisms. But acute community-acquired pneumonia, remember that the hallmark of this disease is that it's acute onset. So this is an acute disease. May occur as briefly over just a few hours of symptoms, but more usually over a day or several days. These patients have abnormal vital signs, fever, tachypnea, tachycardia, although again, you'll begin to recognize that in some patients, particularly elderly patients, the signs may be quite blunted. And for example, a patient could present with just confusion of infection. So these are classic signs of infection in pneumonia, but will not always be present. From a chest exam standpoint, we concentrate on focal chest findings of consolidation. Usually, the most common presentation involves one lobe or just a segment of one lobe, but more serious pneumonias may be multilobar, and you'll hear crackles. Again, if we focus on the two things, consolidation and crackles, most commonly you might hear just crackles. And with a more densely consolidated pneumonia, then you'll hear all the findings we discussed under examination of the chest part 1 for consolidation. You may hear wheezes in patient pneumonia, usually more vocal wheezes because of bronchial inflammation, but not typically diffuse wheezing all over the chest as a classic sign of pneumonia. That would not be the most common thing. Here is a chest x-ray, which again I'm using to show you the internal anatomy of what is beneath your stethoscope and you're examining when you're examining the patient. So this is very extensive pneumonia involving the entire left lower lobe. And you can see that on the left-hand picture is the anterior view of the chest, and on the right hand is the lateral view of the chest. And look, here you can see the major fissure outlined. So again, this involves the entire left lower lobe, and you would have extensive abnormalities over this part of the chest. The second slide here is just again graphically to represent, look at the difference. This is pneumonia now in the right lung, and you can see it in the lower part of the lung here. These are the X-ray changes, and these are less dense. So whereas I can't tell you exactly what this patient would sound like, what I can say is this is not a very densely consolidated infiltrate, and possible that someone with a milder degree of abnormality in the lung, less alveolar filling, would just have some crackles and might not have all the findings of pneumonia, of consolidation. So there'll be a lot of variation in your examination for pneumonia. Now we have a group of diseases we call the obstructive lung diseases, but they have specific names because the pathology and the way they develop is quite different. So the most common ones that you'll see are COPD and asthma. You will encounter a number of patients with cystic fibrosis here at UAMS because we are an adult cystic fibrosis center, and the Children's Hospital has a major cystic fibrosis center for children. And that is a disease which produces obstruction, bronchial obstruction, but by a different mechanism. Bronchiectasis in general from other causes can also give an obstructive picture, and when it's very diffuse and extensive will resemble some of these other obstructive diseases, but they actually are all somewhat different. COPD, when we think about this disease, we want to remember that the history is very important. So even though we're talking about physical exam, you're going to be using your physical exam in the context of the clinical presentation and history of the patient. So remember that the hallmark of this disease is that it is a gradual onset, progressive dyspnea on exertion, and the patients may be completely comfortable without any symptoms at all at rest unless the illness is extremely advanced. So the primary complaint will be shortness of breath while walking or climbing stairs or carrying groceries or some form of exertion, which improves quite rapidly when the patient rests. Other complaints will be cough, chronic cough, a daily cough, a morning cough, productive of sputum, some wheezing, and they may report acute intermittent illnesses where they have increased shortness of breath and cough and sputum, and we call those acute exacerbations. The COPD patient does not commonly have symptoms at night. That doesn't mean they never have them or that no patients will have them, but it is not a common feature. So they frequently sleep quite well through the night, but you ask about it. The examination, I think, is important to point out that on the examination, the physical exam may be completely normal when the patient is not having an exacerbation, when he's at rest, unless the disease is very severe. So that's why the slide describes if severe, you may be able to detect hyperinflation, hyperresonance to percussion, diminished breath sounds, reduced breath sounds, because if you remember your histopathology, there is destruction of the alveolar membrane, and there are enlarged air spaces that no longer function well. So there's more air per unit lung and less lung tissue, and that actually muffles and diminishes the breath sounds compared to the normal lung. The heart sounds may be somewhat distant because of the increased lung between the chest wall and the heart, and they may have a prolonged expiratory phase. So there may be wheezing. I've mentioned wheezing in that line, so they actually wheeze. Or it may be when they breathe out. If you observe the amount of time it takes them to breathe out and complete the exhalation, it's longer by a second or so, just a beat or so, frequently easily detectable, compared to when a healthy person breathes out, because expiration, the phase of expiration, is usually very brief and just, you just breathe out and it's done. So that's why I mentioned that the examination may be normal. And so with COPD, we're moving on to the next line, you really need spirometry. So if you have a suspicion of COPD, that the patient is in the right clinical setting, most are smokers, not all, but the majority have had a smoking history and has progressive dyspnea on exertion. You examine the chest because you may pick up signs of other diseases which could cause similar symptoms, or you may be able to pick up signs of severe COPD, but the diagnosis will be based on spirometry. Then you also need a chest x-ray to exclude other problems. So I'm including this in the idea of examination of the chest or the patient with a chest illness, because in fact we rely on a variety of diagnostic techniques and correlate the physical exam, the symptoms, the pulmonary functions, and chest x-rays or other imaging studies. The patient with COPD is prone to have acute exacerbations, particularly as the disease becomes more severe. So when a patient is having an acute exacerbation, he is more ill, there is a greater degree of obstruction, although in actual change in lung function, it frequently is not a tremendous change in lung function. But the more symptomatic acute exacerbations occur in patients with more severe disease. So they already have very reduced lung function. So when they develop an acute exacerbation, they will be actually observed to have more evidence of obstructed breathing on your examination. So a patient who has quiet breathing may not show much evidence of slow expiratory airflow, but a patient who is trying to breathe faster or is in some respiratory distress, that prolonged expiratory phase may be more evident, and they may be using the inspiratory and expiratory muscles when they breathe. The patient will usually be somewhat tachypnic and tachycardic, not always, but frequently they'll use what we call the tripod position. That means that their body sitting in a chair or the bed forms the base, one leg of the tripod, and their two hands or forearms will be placed on a table or chair or their knees as a brace, and this actually helps them use the accessory muscles for inspiration. And the reason for that is because the diaphragm is flattened due to the hyperinflation. The diaphragm no longer functions as effectively to increase the lung volume for inspiration. And so they use the upper neck strap muscles to aid in elevating the rib cage and being able to take in a breath. The diaphragm is not paralyzed. It's at an inappropriate position for good contraction, and that's what prevents the diaphragm from being as effective. Now, the thing to remember is these patients have a high respiratory drive, and they look like they are working hard to breathe, and they have respiratory distress. So you can recognize this when you observe the patient. They may have wheezes or prolonged expiratory phase, as we talk about. The breath sounds may be relatively diminished, so you can still hear the wheezes, but you may have lost the actual normal breath sounds. And sometimes you don't hear really anything, hardly anything at all. It can be quite dramatic. They have very diminished breath sounds. And then on an examination by percussion, you may be able to detect hyperinflation, where the diaphragm is at a lower position than it normally is. So when you percuss, their lungs are bigger. They go down farther because the chest is taking up more space than normal. The lungs are hyperinflated. If we think of how a patient might look with severe COPD, here would be sort of a classic example. So this man is has several features that we can point out. One, you can see he's quite thin, and but I'll remind you that this is a nice classic example, but many of your patients nowadays will not be thin. They may even be obese, and so you aren't making the diagnosis based on the fact that he's thin. But many patients with advanced disease, due to both the increased caloric expenditure of the work of breathing and also because they become breathless if they try to eat a large meal, so they cut back and don't eat as much at once, will lose weight. And thirdly, there are inflammatory effects of COPD that may actually cause wasting and weight loss. The second thing that you can notice is at this patient's neck, you actually see here, this is the scalene triangle bounded by the clavicle and the trapezius muscle in the back and the neck to the medial side. And this is, you can see it's sort of hollowed out, and that has to do with how the patient is using the accessory muscles. Thirdly, although you can't really see it here because we don't have a lateral view, if you were to look at this patient from the side, this patient's chest would be expanded in the anterior-posterior position. Another interesting thing is look at the position of the patient's lips, and he's using that pursed lip breathing, which actually helps to provide some positive pressure and hold open the small airways that tend to collapse in exhalation with COPD. And then finally, we have him bracing his hands on his knees, and not only his hands on his knees, but his elbows are on the arms of the chair, and this is helping to provide a bracing function so that he can use his accessory muscles to greater advantage. Here's just another example of patients, again, that you can actually observe these findings when you walk into a room or emergency department room or hospital room of a patient who is having a COPD exacerbation or who has just very severe COPD at rest. You can see the example of the pursed lip breathing. You can see the accessory muscles of inspiration shown up in the upper right, and you can actually see these contracting, or you can palpate them with your fingers, and it's not normal for them to be contracting with quiet breathing. And the patient, again, in the lower right has a similar appearance. I'll show a chest x-ray of severe hyperinflation, and this is a very extreme example. This patient had advanced alpha-1 antitrypsin deficiency related emphysema, extremely severe. This is probably one of the most severely hyperinflated chests that I have an example of. So you'll see patients who have much less extreme degrees of this, or even the normal chest and normal chest x-ray, as we talked about. But what you can see is this person has what's called barrel chest, and if you were to listen, if you were to percuss, you're looking at the idea of percussing, let's say posteriorly, using this right hand lateral x-ray. So you're percussing with your hand and your planimeter finger. So you're percussing with your finger, and as you come down, the normal resting diaphragm might stop, right about here or so, and yet as you percuss, you'll be all the way down past really the extent of the rib cage, and it will still be resonant to hyperresonant, which is much larger than the normal lung. So the normal diaphragm would be much higher, and in this case the patient's diaphragm is depressed by the hyperinflation. So you also would not have any difference in the level of the diaphragm on expiration and deep inspiration. He really can't change that. So in other words, the lungs are permanently hyperinflated. He can't actually breathe out to a low lung volume the way you and I can. The next thing is that if you look again at that lateral film on the right and think about placing your chest x-ray anteriorly to listen to the heart, look at the air space, which is the hyperinflated lung, which is between the chest wall and the heart, so that the heart is no longer as close to the chest wall in this patient as it is in a normal patient. And so all of that lung tissue, which is between your stethoscope and the heart, will make it more difficult to hear the normal heart sounds. So the heart sounds may sound distant. You can usually still hear them, but maybe very distant. And you may, in fact, have to listen right under the zippy sternum anteriorly, where the heart is closer to the chest wall there, rather than in your typical normal listening over the precordium. Now, if we move on and think about asthma, asthma is a different disease characterized by inflammation of the airways that is exacerbated by various triggers, either environmental or sometimes allergens, but not always, or even just spontaneously for reasons we don't understand. So the asthma patient is characterized by the ability of the changes in the airways in terms of airway narrowing, smooth muscle contraction, edema of the airways, and mucus plugging of the airways, that these changes can come and go spontaneously or with triggers or with treatment. In other words, they can get better with treatment, but also can get better spontaneously, so that the problem that the patient experiences is episodic, classically. So they can be completely well one day, and then over a period of a day or two, they can become ill with an asthma exacerbation, in which they then will have wheeze, cough, dyspnea, chest tightness, and nighttime symptoms are frequent. So patients with asthma frequently complain of cough or wheezing that wakes them up at night. So the asthma patient, try to get my arrow right here, we talked about has the episodic history. Now that's classic. Some very severe patients with severe asthma that may have gone on to develop some fixed obstruction may have some of these symptoms all the time. But the classic picture is to have varying periods of wellness versus times when the asthma is exacerbating. So the examination follows that. So examination will be completely well when they're normal, but when they're sick, you will detect musical diffuse expiratory wheezing on your chest exam most commonly. The spirometry of the asthmatic, again, reflects the variation in the disease activity, so that spirometry will have an obstructive defect that normalizes or very greatly improves with therapy or spontaneously, and worsens, sometimes very dramatically, when the patient is ill. And again, the chest x-ray is commonly brought into play not because you can see asthma on a chest x-ray, but because you exclude other problems that might mimic asthma with cough or wheezing or shortness of breath. So several of our points of asthma exacerbation are, if we look at this next slide, that the chest exam is not a very good indicator of severity. That you can have a lot of wheezes with fairly mild exacerbation. You can have very few wheezes with a severe one. So when you try to match your ability to serve as a wheeze meter, that means, oh, I hear so much wheezing, that your findings don't track very well with severity. On the other hand, the vital signs, peak flows, and measures of gas exchange are helpful, because as the disease becomes more severe, the attack is more severe, the vital signs will be more deranged, will be more tachypnea, tachycardia, peak flows will be, which is related to spirometry. It's a simpler test that can be done very easily, both by the patient at home or in the emergency department. And measures of gas exchange will deteriorate as the disease becomes more severe. So then you do typically hear wheezes. They may only be expiratory, but they can be inspiratory and expiratory. We talk about, and I think Dr. Tarek will sometimes have a case that emphasizes this, that a very severe asthmatic patient may not be having much wheezing at all, but the other findings would be more pronounced, and so you would develop experience in recognizing that. Patients who are having a severe asthma attack have can have very high increases in intrathoracic pressure and develop a spontaneous pneumothorax or pneumomediastinum. They may have distended neck veins with expiration, and in contrast to COPD, it's not common to be able to detect hyperinflation or a barrel chest. Again, because this is not a fixed, permanent, progressive obstruction the way COPD is, it's episodic. So it may be possible with a very severe attack to have a chest X-ray that shows essentially some hyperinflation, but again, that would be something that would improve as the obstruction subsides. Moving on to cystic fibrosis, because you will see patients with that illness here in this center. Cystic fibrosis is a genetic inherited disease that leads to histopathologically findings of bronchiectasis. And that does manifest itself as an obstructive process. However, it's much different from asthma or COPD, and so we're not doing an exhaustive description of the diseases here, but as we go through, we'll have you recognize that in very early or mild cystic fibrosis, the exam would be completely normal. You would not really pick it up on your examination, but you might instead have a history of frequent infections that may have been diagnosed as multiple episodes of bronchitis or pneumonia, so that even though most patients are diagnosed as children, so those of you who are going to become pediatricians would be engaged in that, we still every year diagnose a few patients, or every few years, several patients who are not diagnosed until they're already adults. But usually they have been treated as though they have had multiple episodes of bronchitis, pneumonia, sinusitis, or other infection, and no one has ever thought that they might have cystic fibrosis. In more advanced cystic fibrosis, then you begin to see physical exam findings of obstructive lung disease with hyperinflation. And what's interesting is the exam tends to show crackles. They don't really have wheezing usually the same way an asthmatic or COPD patient had. The bronchiectasis changes in the lungs actually give a lot of crackle sounds. And the other thing, which is not a chest finding but outside the chest, is that they'll have digital clubbing, very almost universal in cystic fibrosis. Here is a slide to show on the left-hand side a chest X-ray of a patient with cystic fibrosis, and then on the right-hand side is a pathology specimen from a patient who died with cystic fibrosis, so that it may not show up that well here, but what we're really seeing on the chest X-ray on the left are changes of bronchiectasis and scarring. This is not what you see in a chest X-ray of a patient with COPD. So all of these linear densities are the enlarged, thickened bronchi, and there are, again, if we could get you a more close-up picture, you see cystic dilation of the bronchi that forms cysts, and these are filled with mucus, which is a major problem with the abnormal mucus and infection. Here's an example of clubbing. This is something that we do look for in patients who complain of chest problems or have chest problems, because it may be found in cystic fibrosis, it may be found in various types of inflammatory pulmonary fibrosis and in lung cancer. So you look at the fingers laterally this way, kind of from the side, you lose the angle of the nail bed, and it's also a nice palpable finding, so that you sort of bounce the tip of your finger on the nail bed and you can feel the nail bed float or sort of bounce due to a kind of edema of the nail bed, and we don't really know exactly what causes that in the way with a complete explanation. So look for that. Next, we'll talk about lung cancer because it's a very common cancer, and a way to think about it is that lung cancer is what we call a protean disease. That means by the time the patient comes to attention, they frequently, not always, but frequently have widespread disease, and so they may present not with the lung process, but with the evidence of the cancer spread to another organ. So the lung cancer patient may have very important chest findings. They may have enlarged lymph nodes. They may have an enlarged liver. They could present as a first sign of lung cancer with seizures or neurologic deficits due to brain metastases. Clubbing is not always seen, but is a common finding in lung cancer, and then many patients will actually have already started to experience weight loss. Now let's think about the lung findings in lung cancer. And so the point here is that this will depend on the size of the tumor and what else it's causing within the chest as to whether it affects what you think of as the classic chest exam. So the idea would be that if there's a very large tumor, you would actually be able to detect a difference in your auscultation of the chest and even percussion of the chest, because the tumor is now replacing what should be normal aerated lung. The second way that you may pick up findings of lung cancer is that any tumor, even a pretty small tumor, could obstruct a bronchus. So it may obstruct one of the major airways. So then you're not actually hearing a tumor, but what you're hearing is the patient will develop a post-obstructive pneumonia, so that there'll be consolidation, and you'd have changes of consolidation. That's not the cancer, but it's a side effect of the cancer. The second thing that you might detect is post-obstructive atelectasis, and both these two are similar on a similar basis, but one would have more changes of consolidation. The other, if there's significant atelectasis and collapse, would be reduced breath sound and not actual consolidation. And then a final thing is that lung cancer is a very common cause of pleural effusions, or lung cancer commonly causes pleural effusions. So you may detect a pleural effusion and then have to work backwards as to what is the diagnosis, differential diagnosis for the pleural effusion. So here's an example in the next slide of different sized tumors. So if you look up at the, this is a CT scan up in the upper left-hand corner of the slide. And I've got my arrow on that particular picture. So remember, the CT scan takes a cross-sectional slice through the lung. And so I've got a red circle here around what is actually a tiny lung cancer. Now, this patient didn't have any symptoms. This patient was having a CT for some other reason, and they discovered a little nodule on the CT scan. So you can imagine that you would not be able to detect any abnormal physical findings in the chest related to this very tiny tumor. Now, if you look at the CT scan below that, on the lower left, this shows a tumor, and we'll put an arrow on it. This shows a tumor in the left lung here toward the back of the chest. And if you're really good, you might be able to detect a slight difference in the breath sounds in the area of that tumor. On the other hand, you might not, because, you know, it only takes up a few centimeters, and it might not actually affect that much the way the breath sounds are transmitted to your stethoscope. Then if we go over onto the right-hand side, that CT scan here is showing a very large tumor. So here's, I'll put the arrow right in the tumor. This is a very large lung cancer. So you can, I think now, envision yourself examining this person's chest, and because you're going to be a good, careful physician and examine the whole chest, you'll be, if you examine anteriorly here, so you're listening with your stethoscope, you should hear good normal breath sounds here. But then as you come around the back and listen along the back, you would not hear breath sounds. This would be absent or very diminished breath sounds because there's no transmission of sound through that tumor. We talked about how tumors can obstruct, and so here's in the next slide is an example of that, so that if we'll look at the right-hand side first. So let's look at the right-hand side. This right here is a picture taken at bronchoscopy with, we're looking within the main stem bronchus. We're looking inside the left main stem bronchus, and it's completely blocked by a cancer. So if we move over to the left-hand side of the slide now, and we look at the X-ray, you see where the two arrows are. The two arrows are showing where the tumor is blocking the bronchus. So this doesn't have to be a huge tumor, but it's probably bigger than what it looks like when we look inside the bronchus, because it extends further than you can see. But nonetheless, it's not necessarily the physical size of the tumor that's causing so much change in the lung. It's its location and complete blockage of the bronchus. So that if you look at the chest X-ray, the right lung over here, the black, which is a good black, the good charcoal-colored lung, which is well aerated, is over here, and you can see how that would have good normal breath sound. But if you listen over here, on this part of the chest, there is no air going into that lung. That lung is now atelectatic, so the alveoli are largely collapsed, and there's no airflow past the obstruction, so there's no transmission of sound. So you can see that if you were to first percuss this chest, it would be resonant on the left and very dull or flat to percussion on the right. And if you were to listen, you would have normal breath sounds. Wait, did I just say that wrong? Okay, so if I said right and left, I can't remember, but the right lung is the good lung. So the right lung would have good normal breath sounds. The left lung would be airless, so it would be dull to percussion and have very diminished breath sounds compared to the right. And so there you're picking up the effect of a tumor to obstruct the flow, so that with no more fresh air entering and going through all the bronchi to the lobes, there is resorption atelectasis, and gradually the air in the lung is absorbed and resorbed by the bloodstream, and there's alveolar collapse, major atelectasis, and that produces a pretty dramatic finding on examination. You probably have further instruction on the lymph node system, so I'm just mentioning it briefly here, that we show some of the major lymph node chains on the left, and we show on the right the physician examining the supraclavicular area. So this is particularly important for lung cancer, which will commonly metastasize to the supraclavicular nodes. This is important not only for for being alert to the fact that it has spread, but also provides a way to make a diagnosis and stage the patient as advanced cancer by doing a biopsy of that lymph node. And so if we have all the other findings of suspected lung cancer and a palpable supraclavicular node, then the biopsy of choice is frequently a needle biopsy of that lymph node, which may give the entire answer of what's going on with the patient. I mentioned congestive heart failure. I said I would just mention that briefly. Again, trying to show a little bit of sort of a radiographic correlation. So here is a X-ray of a patient with congestive heart failure. They have an enlarged heart. They have the vascular redistribution, blood flow to the upper lobes. They have interstitial edema, and so you may hear crackles, and these are usually either diffuse or significantly in the lower lobes. So it won't be just focal in one side, but should be somewhat symmetrical. You may hear wheezes because the airways develop some edema when there is a lot of pulmonary edema generally. They may have a pleural effusion. There's not one really significant effusion shown on this chest X-ray. And then, of course, you have learned about some of the heart findings, possibly a gallop rhythm, and the patient may have peripheral edema. Going on to pulmonary fibrosis, using as an example idiopathic pulmonary fibrosis. And this CT shows the fibrotic changes, these cystic changes at the periphery of the lung. You can see on both sides of the lung. And so over these areas in particular, you would hear extensive crackles. These actually sound frequently somewhat different from the crackles in pneumonia and the crackles in heart failure. I'm not really trying to propose that you can learn from this lecture how to tell the difference, but if you, as you examine patients, you'll notice a different quality. Again, you really would not make the diagnosis or you would not differentiate pneumonia from fibrosis by the brilliance of your physical exam. I would like to be able to think I would do that, but we don't rely exclusively on the exam. So you would use the radiographs and also lung function tests and some other tests to make that distinction. But these patients with pulmonary fibrosis have what we sometimes call showers of crackles. They'll just be crackle, 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 many little individual staccato crackles per unit of time. It's very dramatic in the classic patient. But there's a lot of variation. So the main thing to remember is that when you hear crackles, there is a wide differential that includes things like fibrosis, heart failure, pneumonia, but you would have all these other things that help you, like the presentation of the patient, the history, other aspects of the exam, and your radiographs. Again, the patients with pulmonary fibrosis frequently have clubbing. So it works both ways. If you're hearing or suspecting fibrosis, you try to specifically be on the lookout for clubbing. If you examine your patient and discover clubbing, you give some thought to the illnesses that can be associated with that, even though it's possible for a person to have clubbing and be normal. But you at least will be thinking about, I wonder if the person has one of these more serious illnesses that's associated with clubbing. So I just asked, what's the diagnosis? This is a picture of one of the tuberculosis hospitals that were prominent before we actually had anti-tuberculous, mycobacterial drug therapy. So here is a chest X-ray of someone with very advanced tuberculosis, which is a nodular and cavitary process. This is extremely advanced, and so it'd be very common for your patient not to be nearly this advanced. This is another patient who has temporal wasting, and you can see that on exam. This is not a specific finding, but it's another example of how you're being observant for things outside the chest that could be associated with chest illnesses. So, for example, a patient with tuberculosis might have lost weight, advanced tuberculosis. A patient with cancer, such as lung cancer, might present with advanced cancer and not have come to the doctor until there had been a lot of weight loss. A patient with HIV disease who's not on HIV therapy or who has progressed despite therapy may have significant weight loss. So for tuberculosis, we remind ourselves to have a high index of suspicion. We continue to diagnose some new cases of tuberculosis in Arkansas every year. And the thing to remember is if you don't think about it, you'll miss it. And it's a terrible thing to have a patient go to several doctors, maybe be hospitalized several times for what's thought to be just a simple pneumonia, and turn out that he's had tuberculosis, and now many patients have been exposed, and the patient himself has not been diagnosed or treated. So remember that we have primary and reactivation TB. I'm not going to go into those differences for this lecture, but the important thing is they may have fairly vague and nondescript symptoms. So they may actually not be very symptomatic. So at early stages of the disease, the symptoms are mild, may be attributed to, just being overworked or tired or the flu or something like that. So the reactivation TB, the patient may have some cough, fever, night sweats, weight loss, anorexia. Hemoptysis is a component, and when you ever hear about hemoptysis, you think about tuberculosis, but it's only in a relatively small percent, and all the symptoms may be mild. The lung findings may be absent or minimal. So the chest X-ray I showed was a very advanced patient where you would have crackles and sometimes some signs of consolidation, but with much milder disease, you might not hear anything. And the chest X-ray would be important because you would likely see some subtle abnormalities in the apex or upper lobes on chest X-ray, and the patient may have clubbing. So if we think now about some symptoms, I think I'll break this up into a second short talk, so we'll take a break and we'll start it back together on the symptoms.